Dr. Reddy, thank you so much for giving the part 3 of this heart failure CME series. Really appreciate it, and feel free to take it away.
Thank you, everybody, for being here. And this is part 3 of our webinar series. And I made slight changes to the name of the topic and how I wanted to do this. So we'll be talking about a case example, a real patient that I have been following since 2019. And the symptom is very common for all of us, unexplained shortness of breath. And this is a true dilemma for most of us who practice clinical medicine. So we'll start with a case example, and as we go along, we'll be talking about the testing and what do we do next, and then within the discussion are some key points relating to the differential diagnosis of unexplained shortness of breath and how we approach this problem. Okay. So I have no disclosures. So this is a 56-year-old woman who was referred by a pulmonologist. So the patient has already seen the primary care physician sent her to the pulmonologist, and then they did what they needed to do, and they said, this is not really pulmonary, and then we'll send to cardiology. So the presenting symptoms were exertional shortness of breath and exercise intolerance for about a year. So like I said, I saw her in the fall of September 2019. So her symptoms were actually going on since fall of 2018. And to make it simple, no other symptoms, no chest discomfort, no other symptoms. So she's a lifelong non-smoker, never used drugs, 10 glasses of wine per week. Family history is all negative and for any premature coronary artery disease. When I first saw her, her pulse was normal, 74 per minute, blood pressure, resting blood pressure was normal, respiratory rate was normal, room air saturation was 98%. She was slightly on the overweight side with a BMI of 28, around 28, and the entire examination was normal, and particularly cardiorespiratory exam. So this is her ECG. As you can see, this is normal sinus rhythm with a heart rate of 73 per minute. Axis is normal. There is no evidence for any left bundle or right bundle branch block, left ventricular hypertrophy, or any ST changes or right ventricular hypertrophy. Nothing to suggest ischemia or infarction. So pretty much totally normal ECG. So whenever I see somebody with shortness of breath, the things that I will be looking for are heart rate issues, heart rhythm issues, or bundle branch blocks. So in the bundle branch blocks, I'll be specifically looking for left bundle branch block. So she doesn't have any of those. And this is her chest X-ray, which looks very normal. So that's her heart, normal size. And those are the two hyla and the pulmonary arteries, not enlarged. And this is her right lung. This is her left lung. Costophrenic angles and cardiophrenic angles and costophrenic angles are sharp. No effusion, no parenchymal lung disease, no pneumothorax, nothing. So everything looks good. So these are her labs, her CVC, except for an MCV of 99, which could be probably from her alcohol use. The CMP with GFR is normal, hemoglobin A1C is normal, except for some mildly elevated triglycerides here. Rheumatoid factor was negative, and then as PCPs, you know a lot more about CCP antibodies, which are more specific in patients with rheumatoid arthritis. That was also negative. Vitamin B12 is on the lower side of normal. UA was normal. And then she went on to have an echocardiogram. So these are all the things we look at specifically in a patient with unexplained shortness of breath on the echocardiogram. So is the left ventricle normal in size? Is there left ventricular hypertrophy or not? and what is the systolic function. And to be detail-oriented, we actually be doing left ventricular mass and relative wall thickness, which were not done in her case. And LV diastolic function. We really need to look into the diastolic function. So what is the E to A ratio? What is the septal E velocity, lateral E velocity? What is the E to E prime ratio? So diastolic function is a key. And then the global longitudinal strain. Again, this also helps. And what is the size of left atrium? What's the size of right ventricle? And whether it has preserved function or not. Valvular lesions. Then IVC, what's the volume status? And pulmonary artery systolic pressure. Does the patient have, by echocardiogram, elevated pulmonary pressures or not? And pericardium. So constrictive pericarditis can cause shortness of breath. And so we'll be looking at that also. So basically, every single part that you image on the echocardiogram has relevance in patients with shortness of breath. And then she had non-invasive testing. So she went through an exercise treadmill test. She was on the treadmill for about 6 minutes and 17 seconds. She could have done better. And she achieved only 7.8 METs. She did achieve 95% of her max heart rate. Resting blood pressure was high, 142 over 93, and peak, almost a hypertensive type of response. But she did not have any chest discomfort. And I'm not sure what happened with the shortness of breath. This was done before she came to see me. But I assume that she probably was short of breath, and there were no diagnostic ST changes. So her Duke treadmill score was 8, which is a low-risk stress test for ischemia. Then she had spirometry, which was reported as within normal limits as per ATS. And then they went on to do a methacholine challenge test to make sure that she doesn't have asthma. And that was reported as negative. And they did not support the diagnosis of asthma. But still, they gave her beclomethasone inhaler, PRN albuterol inhaler, and also Singular and Montelukast, and started treating her as possible asthma. And then they sent her to me. So what is happening with this patient? In the interest of time, so I'll take you through. So when I first saw her, I went through all that testing. And the thing that struck me was the resting high blood pressure and almost hypertensive response, middle-aged woman. So I thought probably what she has is untreated hypertension and causing shortness of breath and exercise intolerance. So that was my preliminary diagnosis when I first saw her. And then what did I do? So I had her record her blood pressures at home for about 4 weeks, and these were high. So I started her on anti-hypertensive agent, educated her about salt restriction, but she still remained short of breath. And I repeated a treadmill test again 7 weeks after antihypertensive therapy, thinking that she should do better. So here is her treadmill test while she continues to take the antihypertensive treatment. Any questions so far? Okay. So this time, last time she was on the treadmill for 6 minutes and 17 seconds. This time she was on the treadmill for 6 minutes and 12 seconds. So it's exactly the same replica. And she achieved, that's a typo there, METs. She achieved 92% max heart rate. And her resting blood pressure was better. But when you look at the peak exercise, her blood pressure was 206 over 95. So she still had the same hypertensive kind of response, but she still had no chest pain, but she had marked shortness of breath with no desaturation. And the test actually had to be stopped because of the shortness of breath. And the way she became short of breath was 3 minutes 2.5 to 3 minutes into the test, she becomes short of breath, and that continues, and it peaks, and then we stop it. And still no diagnostic changes. So looking at this, it's still the same what it was a few months ago. Same findings, no chest pain, still low risk test for ischemia, but her symptom of shortness of breath is significant and with no desaturation. So to some extent, we can say this is not lung, it's coming from somewhere else. So what next? Any ideas on here? So we did the basic blood test, we did the ECG, chest x-ray. We thought probably this was hypertension, gave her antihypertensives, and then we repeated her treadmill test, and she still is the same. No change to her symptoms, still has exercise intolerance, still has shortness of breath. So now we need to think outside the box. So this is the differential diagnosis for exertional shortness of breath for anybody. So the main differentials are cardiac versus pulmonary versus combination of cardiac and pulmonary versus miscellaneous, meaning multiple factors. So when the cardiac causes would be hypertension, valvular lesions, coronary artery disease, heart failure with reduced ejection fraction, and heart failure with preserved ejection fraction, hypertrophic cardiomyopathy, infiltrative cardiomyopathy, by which I mean amyloid or sarcoid, anything that causes infiltrative cardiomyopathy, myocarditis, pericardial diseases. The pulmonary and other causes would be asthma, COPD, reactive airways disease, restrictive lung diseases, interstitial lung disease, pulmonary fibrosis, pulmonary hypertension, thoracic deformities, kyphosis, scoliosis, that kind of thing, neuromuscular disorders, obesity, sleep apnea, deconditioning, anemia, or functional. So this is the extensive list that we need to go through for any patient who presents with shortness of breath. So we did the same with this patient. So then we came down to this list of differential diagnosis in our patient. So what did we rule out so far? We ruled out valvular heart disease. So the echocardiogram did not show any valvular issues, and echocardiogram actually showed preserved AF. So this is not heart failure or systolic heart failure. And there was nothing on the clinical examination or echocardiogram to point to disease of pericardium. Then she augmented her heart rate really well. So this is not chronotropic incompetence. And the pulmonologist already ruled out obstructive airways disease. She's overweight, not obese. She did not report any symptoms to suggest sleep apnea. And she keeps herself fit. She actually runs. That's when she noticed that she's not able to run as she did before. So that's ruled out. So still, there are some rule outs. Coronary artery disease. Did we rule out coronary artery disease? Like I said, the stress test, the Duke treadmill score was low, and it was a low risk study. But still, women can present differently. Though the chest X-ray was normal, I still thought that interstitial lung disease, pulmonary fibrosis were on the differential, and also infiltrative cardiomyopathy. So those are the rule outs. So what are the most likely diagnoses in her case? It would be heart failure with preserved EF and pulmonary hypertension. Okay, everybody with me so far?
There's one question. How does hypertension cause DOE?
So your heart is pumping against high pressures. So hypertension is one of the risk factors for diastolic dysfunction. So it causes a diastolic dysfunction, heart failure with preserved EF, and that's how it causes the shortness of breath.
Okay. Another question here.
How much does hypertension cause dyspnea in the absence of echo findings consistent with the hypertrophic cardiomyopathy? So I think it is still possible, but usually when hypertension causes shortness of breath, you would expect to see some LVH on the echocardiogram, but in her case, there was none. So each patient is different, and that's why we are having this discussion. But I would still consider hypertension. Hypertension would be fairly high on my list when somebody presents with shortness of breath. So we then proceeded on to the next modality, which is diagnostic coronary angiogram to rule out coronary artery disease. And I just put up a couple of pictures. Here you see the left anterior descending coronary artery. That's the circumflex coronary artery. Looks fine. And this is her right coronary artery, which looks normal. So her coronaries are also clean. So now what? So we ruled out coronary artery disease, bronchial asthma, obstructive airways disease, plus or minus hypertension, still on the diagnosis, a differential, valvular heart disease, systolic heart failure. So we are left with what? So we are left with now the same differential of most likely heart failure with preserved EF or pulmonary hypertension. And still, we have the rule outs of interstitial lung disease, pulmonary fibrosis, and infiltrative cardiomyopathy. So we'll keep them there on the list of rule outs, and we'll come back to them towards the end of our discussion. Okay. So how are we going to confirm or refute the most likely differential diagnosis in our patient, which are either HFpEF or pulmonary hypertension? So before we go on to how we diagnose, just some key points about heart failure with preserved EF and why is it important for us to rule out HFpEF in patients with heart failure and shortness of breath. So these are the numbers. So about 50 to 70% of all patients with heart failure have HFpEF, 50 to 70%. And in people over 65, more than 70% of them have HFpEF. So you're looking at anywhere 50 to 70% of patients, of all patients with heart failure have HFpEF. And the risk factors: elderly age, obesity, sleep apnea, CKD, hypertension, atrial fibrillation, diabetes mellitus, coronary artery disease, COPD. These are all common diseases that we see. They're all risk factors or comorbidities for heart failure with preserved EF. And I just want you to focus on two things on this slide. This data is obtained from Get with the Guidelines Heart Failure Medicare patients. So it shows you three things on this slide. This data relates to patients who were hospitalized for heart failure, whether it is heart failure with reduced EF or preserved EF, or patients with heart failure and borderline EF or mid-range EF. Okay, so when they looked at the proportion of heart failure with preserved versus reduced versus borderline, 46% of the patients had preserved EF, 46% of them had reduced EF, and about 8% had borderline EF. So it's 50-50 between reduced EF and preserved EF. And then they followed these patients over 5 years and then evaluated their mortality or survival. So if you look at 1 year, and on the x-axis is the timeline, on the y-axis is the incidence of survival. So at 1 year, about 30% die. And at 2 years, about close to 50% die. And at 5 years, 75% die. So if you have a patient with a reduced EF or preserved EF, and you follow them through 5 years, 75% of them are dead, only 25% of them are alive. And if you look at median survival, which is 50%, right, it comes to about 2.1 years. So 50% of them are alive at 2.1 years. So this is a deadly statistic. That's why it becomes really important that we do everything, assess the patient for heart failure with preserved EF when they present with shortness of breath with unexplained etiology. So now, how do we diagnose this? So this is the algorithm that I suggest we use. And this is more of a specialty algorithm. So I'll take you through this. So there are basically two score systems. The one on the left, H2FPEF score. This is a Mayo Clinic score, the US score. And then the HFA-PEFF score. This is a European score. And so when you see the patient, you assess them clinically, and then you calculate their pretest probability based on clinical examination and echocardiography, okay? And then you put them through these scores. So I go through the Mayo Clinic score. It's a lot easier. There are a lot more variables on the European score, and it's a little challenging to get to all of those variables in the time that we have. So on the H2FPEF score, you have, if your BMI is over 30, you get 2 points, hypertension, 1 point, and hypertension, and you should be on 2 medications. Atrial fibrillation, 3 points, pulmonary hypertension, 1, old age over 61, and filling pressures on the echocardiogram, 1. So imagine if you have a young patient, 20 or 30 or 40, whatever age, and their BMI is more than 30. They are already in the intermediate probability for heart failure with preserved EF. Right? So the low probability is 0 to 1. The intermediate probability is 2 to 5. And the high probability is 6 to 9 on the Mayo Clinic score. So our lady did not fit in with the Mayo Clinic score, but she did fit in with the European score, and her septal E was less than 7, and so she was in the intermediate probability. So from here, then, so for patients with low probability, you do nothing. That technically rules out heart failure with preserved EF. For people with high probability, it diagnoses heart failure with preserved EF, and you may choose not to do anything, but just treat them for HFPEF. But those people who fall in the intermediate probability, like our patient, they go on to have a hemodynamic exercise test. Okay, so there are a few ways of doing this hemodynamic stress test. A non-invasive test, which is stress echocardiography, but it's slightly different from the stress echocardiography that we do for ischemia workup. And the invasive, there are 2 modalities on the invasive: exercise right heart catheterization or saline fluid challenge test. I chose saline fluid challenge test for this lady because it's done easily and you don't need the exercise equipment in the cath lab. And this is one of the algorithms or protocols that is used to do the saline challenge test. So you do the right heart catheterization with the patient resting on the table, collect all your data, and then you infuse 500 cc's of normal saline, warm normal saline, or 7 milliliters per kilogram, very fast over a period of 5 to 10 minutes. And then once the fluid bolus is done, you'll recheck their numbers. So we are looking at pulmonary artery wedge pressure. If it is less than 15 and their probability on the clinical probability is low, then HFPEF is excluded. If they are in the intermediate probability, then you do the fluid challenge. And if their wedge pressure goes up to greater than 18 after the fluid bolus, that helps you make the diagnosis of HFPEF. Okay. And if you have any issues with the wedge pressure, you may choose to do the left ventricular end diastolic pressure. So what did we do with our patient? So I did both pulmonary wedge pressure and the left ventricular end diastolic pressure. So baseline, before we gave the fluid, her mean pulmonary capillary wedge pressure was 12, so that was less than 15. So it was a go for the fluid challenge. And her LVDP was slightly on the high, it was mildly elevated. So I could have stopped there, but I really wanted to see how her pressures did after the fluid bolus. So we gave her the fluid bolus. Her mean wedge pressure goes up to 29. It was 12 and goes up to 29. And for the diagnosis, you only need a pulmonary wedge pressure of greater than 18. So it was severely elevated. And her left ventricular end diastolic pressure, which was 16, which was slightly elevated to begin with, was severely elevated after the fluid bolus. So this confirmed that the patient's ongoing shortness of breath and exertional exercise intolerance were secondary to HFpEF. So once you made the diagnosis, yes, do we have a question?
Yeah, here's a question. So how do you diagnose HFpEF with stress echo, and what do we look for?
Yeah, so that is a topic by itself. There are some diastolic parameters that we should be looking for, and we specifically look for E to E prime ratio. In fact, this lady, I did do that for this patient. Due to time restraints, I did not put that data here. I did not include, but she did have that, and it was inconclusive. But it's not the same stress echo that you do for ischemia workup. It is different. In the ischemia workup, we are looking at wall motion abnormalities and LV systolic function. In patients with diastolic stress test, we are looking at the diastolic parameters. What happens before the exercise and how do they progress through the exercise and at peak exercise.
Thank you.
And once you make the diagnosis of heart failure with preserved EF, this is the differential you need to go through. And I think we did most of these. We ruled out hypertrophic cardiomyopathy, we ruled out constrictive pericarditis, valvular heart disease, coronary artery disease. Myocarditis is not clinically relevant in this patient. She has been having symptoms for over a year, and toxins, she was not using alcohol or drugs or anything like that. And the two things that we did not do so far is ruling out for cardiac sarcoidosis and amyloidosis. So that's what we did after confirming the diagnosis. So we did the screening blood work. Serum kappa to lambda free light chain ratio was normal, and immunofixation, there was no monoclonal spike. And then we did a cardiac MRI. There was nothing to suggest infiltrative cardiomyopathy. And then we also went on to do, I called pulmonology staff and had them do a high resolution CT, mainly to rule out if there is any parenchymal disease or interstitial lung disease, occult interstitial lung disease, or pulmonary fibrosis, and that was all normal. So this lady now has the brand new diagnosis of heart failure with preserved EF in the setting of undiagnosed shortness of breath for over a year. Now, how do we treat? So there are 4 principles of treatment for heart failure with preserved EF. So number 1 is volume control. Number 2 is blood pressure control. Number 3 is medications. Number 4 is risk factor management. So this is these are the 4 pillars of treatment for HFpEF. So talking about the volume control. So class 1 indication based on 2017 guidelines, salt restriction and diuretics to maintain euvolemia. They may not need maintenance diuretics, but each patient is different. Blood pressure control, systolic blood pressure less than 130, and diastolic pressure less than 80. It's a class 1 indication, again, based on 2017 ACC AHA guidelines. The guidelines don't mention the diastolic, but I use 80 and less than 80 based on other anti-hypertensive guidelines. So volume control, blood pressure control. And this is the list of all the trials that were done to see what group of medications would help patients with HFpEF. They used ACE inhibitors, they tried ACE inhibitors, they tried ARBs, they tried Sacubitril-Valsartan, they tried beta blockers, MRAs, you name it, they had it. So they are all either neutral or negative. And Champion trial is not actually a medication trial, it's actually a device trial, which is CardioMEMS, and we won't get into that due to time restraints. And so the medications that are, you can use beta blockers, ACE or ARB for blood pressure control, no preference, but there is a class 2B indication for ARBs over the others to decrease heart failure hospitalization. Similarly, spironolactone, class 2B indication to decrease hospitalization for heart failure. So far we have ARB and spironolactone as 2B indication to decrease hospitalization. Then this is new from February 2021. Sacubitril-Valsartan now has expanded indication for use in chronic heart failure. The evidence for that is from Paragon heart failure study. So this study compared sacubitril-valsartan to valsartan in people equal to or greater than 50 years, patients with heart failure with preserved EF, and they looked at cardiovascular death and total hospitalization. And it was actually a negative study, but the subgroup analysis pointed to some benefit in patients who were receiving sacubitril-valsartan in those people whose EFs were equal to or less than 57%. So this was reviewed by FDA, and they now approved as an expanded indication, not only for heart failure with reduced EF, which is less than 40%, but you can use it for patients whose EFs are between 40% and up to 57%. So it's a class 3 indication, no to oral nitrates. So please do not use Imdur or isosorbide dinitrate or phosphodiesterase inhibitors. And risk factor modification, if people have coronary artery disease, you revascularize them. If people have atrial fibrillation, you treat them atrial fibrillation based on guidelines. And of course, the same goes for sleep apnea, weight reduction, COPD, all of the management. So our patient, she is doing well, not as short of breath, continues to exercise. She follows heart healthy diet and low salt. Her BMI is still 27. It's a typo there. And she was 27.7 when I first saw her. It's lower. And her blood pressure is consistently that. She's on spironolactone. And in March 2021, I switched her losartan to sacubitril-valsartan before she was on valsartan. And with the new expanded indication, I'm using sacubitril-valsartan on all my patients with heart failure with preserved AF. And then she needs torsemide occasionally, and no admissions or ER visits. So what are the conclusions? So always in patients with unexplained shortness of breath, always consider heart failure with preserved EF in the differential diagnosis. Then follow the scores that I showed you in identifying patients. And your workup is incomplete until you do the hemodynamic stress test in patients with the intermediate probability. Your workup is incomplete. So please send them our way. Or if you do yourself, you should do them. And then rule out the other causes of HFpEF, like I showed you, particularly the infiltrative ones. So that's all I have. And
so you can feel free to unmute yourself if you have questions for Dr. Reddy, or you can type them in the chat field if you're shy. But feel free to unmute yourself and ask a question, or type it in the chat field. So there's a question. It's really for me, actually. So yes, we are recording this presentation, and we will have it available on YouTube in probably a couple of weeks. The last two talks, the first one, which was, remind me again, Dr. Reddy.
it's June 18th, I think, on the MLR doses.
Yes. So that one is available on YouTube, and I can put the link.
Did you say the last two talks?
The last two talks.
So one was on systolic heart failure.
That's right. So those are available on YouTube, and I'm going to send out the links to those. And we're going to place this one in the next talk on YouTube as well. So I will put up our flyer so you can see that. If you want to stop sharing, Dr. Reddy. And it looks like we have a couple questions.
So somebody is asking me, can we diagnose heart failure with preserved EF from resting echo? So the simplest way to diagnose heart failure with preserved EF is this. They should have three things. Clinical symptoms and signs for heart failure. They should have a normal ejection fraction. When I say normal, equal to or greater than 50%, and they should have some degree of diastolic dysfunction. If you have those three, and echo is very good at diagnosing the diastolic dysfunction. So if you have those three, I think you can make the diagnosis of HFpEF. You don't have to go through this whole process. And if you apply this simple, the Mayo Clinic score, and if your score is 6 or greater, then you have the diagnosis. So would chronic/recurrent PE appear like this? Any recommended testing? Yes, it does. It does. So chronic recurrent PE can cause right heart failure, and right heart failure is one of the differential diagnoses for unexplained shortness of breath. And I would go through the same, and I think you should be able to see RV enlargement and right heart failure clinically and on the echocardiogram. And then their pulmonary pressures would be, it's going to be, they will have pulmonary hypertension, and that is what is going to help you. The difference in the pulmonary hypertension between HFpEF and the others is it's pulmonary venous hypertension in patients with HFpEF. Anything else?
So far, nothing. I'm also putting in the chat field the link to claim your CME credit for this talk, as well as the instructions about how to claim your CME credit. Again, feel free to ask a question, type it in the chat field, unmute yourself if you're not shy, and we are happy to answer it. But if there are any questions, we'll thank everyone now. Thanks for joining this series. Again, up on your page that you can see right now is the next talk, which is June 8th, same time, noon to 12:45. And it's about recent updates in amyloidosis, ATTR.
I think it's June 18th then.
June 18th, did I say?
8th.
Oh, June 18th, sorry about that.